So good morning, everybody. I'm Catherine Thompson, and I head up the Cardiovascular Disease Prevention Programme in Public Health England. Today, I'm really pleased to say we're joined by Dr. Lou Aikins, who's a consultant in behaviour change, intervention, design and evaluation at University College London. And Lou's going to be sharing findings from a recent scientific paper called The Influences on NHS Health Check Behaviours, a Systematic Review. And this is a piece of work that PhD commissioned UCL to undertake and that fed into our work on the digital exemplar. So some of you may well have joined a webinar that we did a couple of weeks ago, which looked at the findings from the digital exemplar work that we did. And this is more of an in-depth dive into the evidence review that was undertaken that fed into that work. So I'm going to hand over to Lou, and then, as I said, we'll have time for questions and at the end of Lou's presentation. So Lou, over to you.
Thanks very much, Catherine, and thank you for inviting me to talk about the work that we've been doing over the last couple of years. I'm sending warm greetings from Auckland, from the other side of the world. I lead the Australasian hub of the Centre for Behaviour Change, but proof of our remote working capabilities to work on this project. I'm going to pop my video off. I just wanted to say hello and be seen, but not to distract from the presentation in hand. So if we could just nip to the next slide. Okay, so first I'd like to just acknowledge colleagues that we've worked with in Public Health England, Tim Chadbourne, Chris Stefanado, Catherine Thompson and Andrea Hewins, and my other chums in the UCL Centre for Behaviour Change, Susan Mickey, Fabio Loncato and Celia Zink. And you can see in the bottom left proof that together we produced a paper that was published in BMC Public Health earlier this year. So to the next slide. So thanks to Catherine for sort of setting up the stall in terms of how this work came about, and essentially to strengthen the evidence base around NHS health checks. We followed what are essentially the first steps you take when you design an intervention. So the aims of the study, firstly, were to identify what are the behaviours involved in NHS health checks, and this is in the context of primary, community and social care, and who are the people performing them. Now, to do that, we conducted a systematic literature review. We had a panel of experts that we consulted with to ensure that we were being comprehensive in terms of the literature and not missing anything out. Then the second stage, having identified who is doing what, is then to understand the behaviours, what influences those behaviours. And these influences were classified using a theoretical model of behaviour. Now, before everybody signs off the call, because nothing gets people running for the hills quicker than behavioural scientists bringing out their boxes and arrows, will kind of hopefully convey to you how we use that sort of pragmatically and practically to synthesise the evidence. And so having understood who is doing what sort of factors are influencing those behaviours, we were then able to develop some potential or signpost to potential interventions of how interventions could either be developed or existing interventions tweaked to better target the influences on NHS health check behaviours. To the next slide, if you would. Okay, so here are the boxes and arrows, and it's the only one, so that's good. But we used the simplest model of behaviour that you can think about. So for any behaviour to occur, 3 conditions at its most basic level need to be present. One needs to have the capability to perform the behaviour, and that can be physical capability, but also psychological capability. So having the knowledge, the cognitive interpersonal skills, the memory, behavioural regulation, so be able to kind of like monitor and adapt. One also needs the motivation to perform the behaviour. Reflective motivation. We have to have our kind of higher level thoughts around belief structures, what we believe is worthwhile doing, what we value doing, what we intend to do, goals we might have, our kind of social or professional identity, and how much we think we can through optimism, how much we think we can achieve that goal, but also automatic motivation, which is concerned with the area sort of closer to our animal brains around kind of emotion. What are our wants, our needs, our habits, and so on. Those are within the individual, but we also need the opportunity. So the environment, not just the physical environment in terms of having the time, the money, the right equipment, the resources, the access that the physical environment affords it, but also the social opportunity as well, the support from others, that this is something that others are doing, so social influences. And I should point out that we have our simple model, so COMBI being capability, opportunity, motivation leading to behaviour. And I've just added in just some constructs to the left of that illustrate a little bit more using a different tool, how one can break those down. So that's what we used for identifying the influences. And to the next slide. And you'll see a kind of step diagram there in terms of what behaviour are you trying to change. So that was kind of aligned to our first aim. What will it take to bring about the change? And you see the COMBI model next to that. And then you see 2 other tools there in terms of broad intervention strategies, and specifically in terms of what techniques are you going to use to bring about behaviour change. And those are linked to the COMBI model, both the what's called the behaviour change wheel, which is a framework kind of linking COMBI to signpost you to types of interventions to consider, and then from there types of particular techniques that might serve those broad intervention types. And we've summarised that in our behaviour change wheel guide that we published a few years ago, but possibly more relevantly published earlier this year, Public Health England Guide to Achieving Behaviour Change. So this is a guide for local government and partners, and I believe that there is a national guide that is coming out very shortly. So those are the steps, and that was a sort of abbreviated methods. If we can go to the next slide. And the other aspect to the methods is one can use these tools which are applied without context, but of course we're applying them to different contexts. So how can we do that in a systematic and transparent way? So this APPEASE criteria is essentially a checklist for major factors to consider when thinking about, okay, we've got a number of things that we could potentially do in an intervention to target a particular influence. Which do we choose? And this helps guide the decision making. Can we afford it? Is it practicable, i.e. can it be delivered to scale? Is it effective? Either evidence of effectiveness, or just simply sort of plausibility? Is it likely to be effective? Many can be discounted from this. Is it acceptable to those who deliver it, to those who receive it, to those who commission it? Is choosing a particular intervention strategy, does it have any side effects? Are there any unintended consequences as a result of going a different route? And is there equity as well? Will it disadvantage any groups or individuals? So that's sort of taking a one-size-fits-all approach using COMBI and then to select particular behaviour change techniques, but then using this criteria to tailor what is selected to the context in which you're working. And we'll run through how that was mirrored in the evidence synthesis that we conducted. So to the next slide. So systematic review, we identified 37 studies. I've just put a brief version here. There is, I think you'll have seen there's another version at the end containing more information, but the majority of studies looking at anything to do with engaging in NHS health checks were focused on patients, some just on healthcare professionals, a couple on patients and healthcare professionals, and some practice managers as well, practice managers, commissioners, and commissioners. And you can see there that the majority were conducted in primary care, with significantly less in community, and then just a couple in primary and community. So that's that sort of gives you an idea of where the weight of the evidence comes from. And if we can go to the next slide. So our findings for AIM-1, and apologies for the tiny font there, we constructed a kind of very high level map of who is doing what relevant to NHS health checks. And I should issue the caveat that, of course, a lot of this is sort of motherhood and apple pie. But at the same time, what we wanted to do is, as a basis, is like, right, who is doing what, and then on top of that, as we'll see in I believe the next slide, what is influencing that particular behaviour or set of behaviours in the chain. So we start, healthcare professional invites patient for the health check, either written invitation, phones, opportunistic invitation. The patient attends, they've got to attend the blood test, then the check. Healthcare professional delivers the check, communicates the cardiovascular disease risk, provides behavioural support, and they either refer them on to a specialist service. And I realise one of the arrows has gone awry, because that then should go to patient attends, specialist referral, and then the extent to which patient changes behaviour, so smoking cessation, diet changes, physical activity, statin, and then within the health professional line of behaviours, after referring to specialist service, records NHS health check data, and then service managers, commissioners synthesise and disseminate that, and then back to the patient after changing their behaviour. And I say this in, you know, a logic model of how we anticipate things flow. These are the behaviours that should happen, but of course there are barriers and facilitators to all of those. But after the patient checks, they attend a repeat NHS health check. So that was our first job, was just to kind of map this out. And this was helped by sort of at the same time looking at what looking at studies that had looked at what hinders or promotes engagement with these particular behaviours. And for the purposes of the work that we were involved in with the digital exemplar programme, we identified a couple of behaviours and a couple of influences on behaviours from which to develop examples of how one might target those. So if we go to the next slide. So overlaid there, so we took sort of two behaviours. Obviously in the systematic review, we've kind of comprehensively reported the influences on all behaviours, but for the purposes of working up examples, we took the delivery of the NHS health check and the influences on whether or not patient changes their behaviour afterwards. So in terms of delivery, we were looking at, well, what are the sorts of things that are key in this, and one of the things that came out was offering behavioural before pharmacological support. So to do that before jumping in with pharmacological support. There was a range of opinions on how familiar people were with guidelines. So the reason why I'm sort of harking back to the combi model, because these are surrounded in red. So these are sort of capability, sort of knowledge and memory issues around sort of knowing what to offer and when, and also being familiar with the guidelines. But something else came out as well, was that in the yellow, which is motivation, so having the confidence to actually discuss and initiate change, or support the patient rather to initiate change. Again, range of opinions on that. Some felt confident, it was part of their role. Others felt, I don't think this can be done. Also around the framing, appropriate framing of CVD risk message. And you won't be surprised to see that in terms of the environment, simply having the time and the resources to deliver the excuse me, deliver the NHS health check came up time and again. We moved to the patient changes, support from others, having family to encourage them was important, having knowledge of their risk and the implication of that, opinions on how much people actually understood about their risk and whether there was any perceived need to change behaviour. Some perceived it to be a real wake-up call for change, regardless of knowledge or risk. This was a wake-up call that they had, and also the belief that change is achievable, and that was sort of there were diverse opinions there. So we have these particular factors, the influences on health check behaviours that we think, okay, if we're going to sort of follow the track of developing an intervention, how then do we target these? So if we can go to the next slide. So we identified the behaviour, we identified the influence in terms of the nature of the capability issue. Was it guideline familiarity, the motivation influence? Was it confidence to initiate discussions? Was it opportunity? Was it the time to deliver the health check? And then, as I mentioned, the Behaviour Change Wheel Guide and the Behaviour Change Techniques Taxonomy signposts from influence to potential interventions that one might consider. So these linkages essentially put you in the ballpark of areas one might explore. And then one uses the appease criteria to further tailor that down to your own context. So of these that's put me in the ballpark, what can I afford, what's practicable or scalable to deliver, what's likely to be effective, any side effects, so on and so forth. So that was how we then worked up a number of examples. I don't propose to go through all of these, but just to give you an idea of the process that we went through for the first couple. So if we can move to the next slide. So potential interventions to promote healthcare professionals offering behavioural before pharmacological support. So the behaviour was around delivering the NHS health check. The influence on behaviour was kind of characterised as being a psychological capability issue and remembering to offer kind of pharmacological support. Now, the linkages between the influences in COMBI and the larger behaviour change wheel framework put us in the ballpark of either training, environmental restructuring, or enablement. And again, that's a kind of short list of all possible intervention types, but not particularly applied to context. So when we get to the behaviour change technique level, so specifically how are you going to train or restructure the environment or enable, something like prompts or cues, which is a particular technique. And we worked up just examples that were particularly for the digital exemplar. So prompts and cues, a stimulus to prompt or cue the behaviour. For example, a screen pop-up reminding the healthcare professional to offer behavioural support first. You know, so far so good, sounds, you know, kind of obvious, but people are, as you know, dealing with particular different contexts. So if we move to the next example, I don't propose to talk through all of them, but I think the next one sort of indicates the process. So interventions to increase healthcare professional familiarity with relevant evidence-based guidelines. Again, the behaviours around delivering the NHS health check. We weren't specific on behaviour. We were often dealing with kind of bundles of behaviour. So again, this is a kind of psychological capability issue, a knowledge issue that signposted us to education. So what are the ways in which we can do this? Instruction on how to perform the behaviour, so providing healthcare professionals with electronic summaries, information about antecedents, text on website or app suggesting healthcare professionals be mindful of situations such as busy clinics where guideline content might be overlooked, information about health consequences, so electronic content explaining to healthcare professionals adhering to evidence-based guidance can improve patient health outcomes, the salience of consequences, something that's sort of bringing, you know, a more kind of emphasizing consequences using imagery or metaphor to kind of hit home the message, or information about social and environmental consequences. So there are a number of options. What this going through this process did is provide a number of options where one or more might be acceptable, affordable, practicable, and so on. And in one of our workshops, we actually worked through this and applied the appease criteria, sort of took one of these examples just to work through what would be most appropriate for or which techniques, or just a single technique, we could deliver on the digital exemplar platform. So I'd like, at this point, I'm conscious I've been talking for sort of 20 minutes or so, and I've been advised to try and limit that. There are a number of other examples, and I know that the slides have been circulated in advance, but at this point, if I could loop Catherine into the discussions. We have a number of other examples. I'm happy to talk through those, but I wonder whether at this stage it might be helpful to pause and take questions or signpost to future work.
Great, thanks Lou, for such a comprehensive overview of the work that we've done. And I think what I would add to that is, while the work was undertaken with a view to using the findings to inform our digital exemplar, I think colleagues on the line will really see how transferable this learning is to the programme in its current form, and you know, how you might also use this framework and some of these examples almost to help you think about what else might be done with your local service in its current guise to really try and maximise the chances of influencing the behaviours of particular interest in a favourable way. So what we're happy to pause there.